Good morning, everyone. Thank you for joining us this morning. I'm really pleased to welcome you to the Health Foundation webinar on how to talk about the building blocks of health. If we want to change the way that the public understands health inequalities and to change policy, we need to change how we communicate about the factors that influence health. And this webinar is about how we can make that change. My name's Gwen Nightingale, and together with my job share partner, Catherine Merrifield, I'm one of the assistant directors in the Healthy Lives team at the Health Foundation. And in that team, we aim to change the conversation to focus on health as an asset rather than ill health as a burden, and to promote policies that improve opportunities for healthy life in the UK. We've got a really great panel of speakers this morning, and I'm expecting a rich debate. There's going to be lots of opportunities for questions. And if you enjoy the session and would like to listen to it again or share what you hear with colleagues, the event's going to be recorded and the video will appear on the Health Foundation's website within 24 hours with a subtitled version following afterwards. Shortly, we're going to start the session off with Louise Marshall, who's a Senior Public Health Fellow at the Health Foundation, and she's going to set the scene about where this work came from and why the Health Foundation got involved. We're then going to hear from Tamsin Hyatt, the Director of Impact at Frameworks UK, who's going to set out the work that they've been undertaking with us around framing. And then we're going to hear briefly from three people who've been putting some of this work into practice. So we're going to hear from Tim Andrew, who's the organisational lead for strategy, planning and change at Public Health Scotland. We'll then hear from Claire Laurent, who's a consultant in public health at Hertfordshire County Council. And then finally, we'll hear from Liz Such, who's the Anne McLaren Fellow at the School of Health Sciences and National Institute for Health Research Knowledge Mobilisation Research Fellow at the University of Nottingham. So before I hand over to Louise, I've got a few bits of housekeeping. I mentioned that there'll be lots of opportunity for asking questions. We're going to be taking questions in the last part of the webinar, but if things come up during the discussions, feel free to ask them, and I can try and weave them in later on. You can ask questions using the Q&A box at the bottom of your screen to submit questions. And if you see a question that somebody else has asked that you'd really like to hear the answer to, you can upvote those questions by clicking on the thumbs up icon in the question and answer function. And we'll try and answer the most popular questions that catch our attention. And thank you very much to everybody who submitted questions in advance. I've got a list of those and I'll be trying to weave those into the discussion as well. I'm now going to hand over to Louise, who's going to give some background on the Health Foundation's involvement.
Thank you, Gwen. So there's compelling evidence about the role of the wider determinants of health and about socioeconomic inequalities in health. And at the Health Foundation, we've developed what we thought was a clear story to tell about the aspects of our lives that influence our health and how long we live. From our jobs to our homes, our access to education and public transport, to whether we experience poverty or racism. But this story about the wider determinants of health struggled to get cut through in the public, media and political debate. People's attention too quickly turned to what individuals should do in terms of their behaviours and what the National Health Service could do. So we decided we needed to frame health communications differently to tell a more powerful story. A story to increase understanding of the role of the wider determinants of health and to build support for the policies needed to reduce health inequalities and improve health across the country. So this is why we commissioned frameworks to help us understand how people think about health and to develop new ways of talking about the wider determinants of health and health inequalities. So before we hear about this work from Tamsin, I've got two questions for you all. You should have a poll pop up on your screen for simple yes or no answers. But we'd love it if you would expand on these in the Q&A box that you've got at the bottom of the screen, as we'd really love to hear some detail from you. So the first of these, which hopefully you can see on your screen now, is have you found it hard to convey messages about health? a moment to answer that. As I said, we'd love to hear any detail in the Q&A box, so please do share things there. And then the second question is, have you used our framing toolkit already? And just from the first poll there, I had about the majority of people, it flashed up very quickly and then went away, but I think it was about 87% of people saying they had found it hard to convey messages about health. And then on the second question, have you used the toolkit already? The majority, 90% of you, have not. So hopefully, following hearing about the research in the toolkit today, we can signpost you to that, and our hope is very much that you find it a useful resource in future. So I'm going to hand back to Gwen now, and look forward to speaking to you more later.
Great, thank you very much, Louise. One point I forgot to mention earlier, apologies, was just if anybody wants to tweet about this event, please use the hashtag #TalkingAboutHealth. Yeah, it's been quite a journey, this piece of work for the Health Foundation, and it's helpful for Louise to set the scene about what happened many years ago when we first started thinking about this, and been really delighted by the interest that the recent work that we've published with Frameworks has generated, and in the interest in this webinar. And I'm going to hand over to Tamsin from the Frameworks team, who's going to set out a bit more about the work.
Thank you, Louise and Gwen. I'm going to jump into the screen share. And hello, everyone on the webinar. It's good to be sat around the virtual table with you. As a quick introduction to Frameworks, we spend our time researching two things: how people think about an issue and what changes those things. The approach we take is multidisciplinary in nature, drawing from psychological anthropology, linguistics, and the cognitive sciences. And we take our research, our framing insights, and work in partnership with mission-driven organizations for change. Here are some of the organizations we've worked with over the last few years. We focus mostly on issues around children and families, homes, poverty, and health. Let's jump in. As Louise has said, our health is shaped by the world around us. Our jobs, our homes, access to education, public transport, experiencing poverty or systemic racism, these all impact our health and how long we live. But in political and public debates, these wider determinants are either missing or misunderstood. And this is a challenge for all of us working to address health inequalities here in the UK. Because when people struggle to see how our world works, how jobs, homes, hardship affects health, it's harder for them to see how our world can and should work differently, to support and to demand policy and practice that addresses these wider determinants. As Gwen and Louise have said, the Health Foundation partnered with Frameworks to help meet this challenge, to develop new ways to talk about health that build understanding and support for change. And we started with research, first exploring how the public think about health now, and then testing ways to shift that thinking. This was mixed method, quant qual, including surveys, interviews, and discourse sessions with over 7,700 people across the 4 nations. I'm going to take us through a few findings today, and I only have about 20 minutes, so this will be a snapshot. All of our findings and how you can bring them to life in your communications are in the new toolkit. And so we have that shared definition here. Framing is about making choices, about how we present information, how we tell our story. It's what we emphasize, how we explain an issue, and what we leave unsaid. And these choices are powerful because when we get them right, they create radical changes in how people think, feel, and act. I'll show you what I mean here with some footage from our work on child obesity. One interview, one man asked about child obesity 2 times. Your challenge is to spot the difference in the before and the after clips, because in between takes, he was read a short, well-framed message on child obesity.
And how about child obesity? What comes to mind when I say that?
Immediately, I'm thinking that maybe the parents are coping with their children in maybe the wrong way. They're feeding them too much, giving them food to keep them immediately happy, and not considering the longer term benefits of eating healthily.
What would you say needs to happen for child obesity to go down?
Well, as I said, it's eating less and moving more, really. Yeah, I often say to myself, I'm surprised that we are still allowed to advertise certain things on the TV as we do. Perhaps there should be some tighter restrictions on how the advertising takes place these days. It just comes down to the things, the producers of food. If they're making stuff that's going to make us unhealthy, that needs to be addressed. To how the food is marketed.
Did you catch that? His thinking changes from blaming individuals to looking at systems, advertisers, food producers. This shift away from individual and towards individual in context is exactly the change in understanding we need to make on the wider determinants of health. And there's one more thing that he says that's important here in his after clip. He says it all comes down to, and I often say to myself, even though he is saying something very different, because these are both strong linguistic cues that he thinks these things anyway. They just weren't top of mind. Context was not immediate and obvious to him until he was given the right frame. So our words matter, our frames matter, because they shape how issues are seen and understood, not just in conversation, but also at scale. Here are just a few examples from recent years. Take the smoking ban. The story here was framed as one of personal vice. Individual smokers just needed to stop smoking. But campaigners, practitioners, and advocates changed the frame, told a new story about how secondhand smoke kills bar workers, and we all have a right to a safe workspace. This new story and the changes in public thinking it led to the 2006 Health Act. All of these used framing to mobilize people around a very particular story, to drive attention to systems and to context, to show why their issues mattered and how they worked. They all succeeded in changing how people think and at scale. And this is what we need to happen on the wider determinants of health if we are to secure the change we need in time for it to make a difference. So let's start with how people think about health, the mindsets, the mental shortcuts that people draw on. We're going to watch a short video that illustrates broader research findings. It's worth noting that mindsets are implicit and are shared. They shape our understanding without realizing it, how we think and act in the world, and they shape our expectations about how our world should work. Let's watch.
So what comes to mind when you think about health?
Looking after yourself.
Diet, exercise.
I think about the food I eat, mostly I think, and exercise.
I don't smoke, don't drink, don't do drugs, don't do anything like that.
When I think about health, I'll think more like generally about like maybe the NHS, doctors, stuff like that.
The NHS.
Hospitals and the NHS.
How would you define health?
It's an absence of ill health.
You're supposed to feel like healthy every day, so maybe it's something you don't notice as much.
If nothing's bothering you, then you are healthy.
So by not having a cold, you'll be happy to go outside and do outdoor activities.
Whereas when you feel unhealthy, you definitely notice it.
The mind, so you've got like mental health as well.
So people think about health in highly individualistic ways. We're healthy or not because of the choices that we make, if we eat and if we exercise. Health is seen as the absence of ill health. It's all about the NHS and not our context. So these are not the only ways in which people think about health, but they are the most dominant and the most challenging. Because if health is just the absence of illness, just reactive NHS care, it's harder to see how what surrounds us shapes us. It's harder for people to see how society can make changes to create and promote health. And if context is missing from people's thinking, they default to those individualistic ways of understanding the world. For health isn't about working multiple jobs, poor quality housing, lack of green space. It's about making bad choices, not taking care of yourself. And for some, this can lead to fatalism, because they'll reason that some of us will always make bad choices. So we need that new story about health, one that makes context immediate and obvious, one that answers the questions: why do the wider determinants of health matter? How do they affect health? And what can we do about it? And it's worth noting that when we answer all of these questions, it taps into what's known as a fluency heuristic. The story makes sense to us, and we're more likely to accept it and engage with it. So while we're not exploring all of our new story today, I'll share an answer to each of these questions. First up, start with why the wider determinants of health matter. Health is salient in public thinking. It's seen as important, but it's not seen as urgent. So we need to be clear about what is at stake, why action on the social determinants should be a priority for government and for the public. And we tested a few ways to answer this question, to shift thinking towards not only salience, but also support for policy change and our collective responsibility to make that change happen. They're the labels here on the x-axis. And one of the ways in which we frame test is essentially a randomized control trial. We ask a set of questions to sample groups after exposure to a frame, alongside a control group, that thick black line at 0, who hear nothing. And we measure the shift. We tested. This matters. We should care about it because it's all about improving health creation. That this matters because we need to be tackling poor health. We need to be helping people to build longer, healthy lives. And also, this is about preventing lives from being cut short. This fourth frame, that lives are being cut short, created the most significant shifts. The idea that some people are dying earlier than they should, and people in our poorest towns and cities are dying many years earlier than those in wealthier areas. Action on the social determinants of health is a matter of life and death. And this is what we need to lead with if we want people to pay attention, to understand what's at stake, and to act. It's not enough to talk about health and well-being in general. Well-being is always seen as a matter of degree. Life and death is not. And like Louise has mentioned, health alone, be it creation or prevention, is a powerful cue for lifestyle choices. Life expectancy helps bring context into view, particularly when we can make this about place, not person. That people in some places are dying earlier than they should. And this frame, although it worked across the political spectrum, was particularly effective for those who identified as right-wing. It's worth noting that we should try where we can to avoid concepts like disability-free life expectancy or healthy life expectancy. In testing, we found that people just don't know what these terms mean. And the added technical complexity creates psychological distance. If I'm not already expert, these signal that this isn't for me. It's a problem for other people, one that they need to solve. And we need everyone to have a stake in taking action. A second finding, we need to explain how wider determinants affect health. People's inability to understand how and why the world around us shapes us are these two big challenges for communicators. So we need to build out this understanding deliberately and intentionally, and do this in ways that are accessible, understandable for people with busy lives and multiple competing priorities. Because how we talk about a problem sets up the solutions to it. Who people see as responsible, who should act to solve it, and how. So let's take a look at how people think about the solutions to health inequality. How people answer the question, how can we improve health? And again, we have another video that illustrates broader research findings. Let's watch.
What needs to happen for people in the UK to become healthier?
Yeah, I'm not sure. I can't think of how else, like...
That I have no idea.
General sort of knowledge of what is and what isn't healthy.
If they had more of these documentaries on TV, where when people were bored, they got to watch and learn these things, I think it could make a big difference.
I think education through schools as well.
Unprompted. The only solution that is top of mind for people is education. It's individuals learning to make better choices. It's not changing the systems and conditions that shape and constrain decision-making. So we need to fill in the gaps to build people's understanding of the social drivers of health and how they work. Because without more, people fill in the gaps themselves, draw on mindsets and assumptions that we know aren't accurate, like individuals just need to make better choices, eat less, work harder, move more. Explanation can bring people with us, build understanding and drive support for systems change. Because the more people understand how our world works, step by step, the more they can see how our world can work differently. I'll walk us through what's at stake here. With a quick example, talking about that top of mind solution, education, as one of the wider determinants of health. If the only thing we talk about is correlation or prevalence, if the only thing we say is that lack of access to education leads to poor health, people fill in the blanks like this, that some children don't have access to a good education, so they don't understand the importance of exercise and eating well. So they make bad choices about food and exercise, with our result, poor health. As people reason between cause and effect here, it sets up a very specific solution. It's education, awareness raising, behavior change campaigns. It's the campaign that tells you to eat 5 a day, but not how that 5 a day should be accessible or affordable. Here's how we could fill in the gaps, step by step. Some children don't have access to a good education, so they graduate, if they graduate, without strong qualifications, which limits job prospects and income. So they can only afford poor quality housing. So they're exposed to damp, to mold, to the illness of others, with our result, poor health. As I have explained this step by step, it's that much harder for people to default to health individualism. There's no room here to blame individuals. And it sets up a very different solution. It's systems change. It's strengthening the building blocks that make up our communities. In this case, our education and our housing systems. On to our last finding. After we have established why the determinants of health matter and how they work, we need to show what we can do about it. Because people have a tendency to think very fatalistically about the way our world works, especially the big things like economies and industries. People think that systems are just too big, too complex to change, or that social problems are too entrenched, too catastrophic to fix. And right now, the language of crisis, of disasters and emergencies dominates communications on public health issues. And right now, we are facing and fighting one crisis after another. And when everything is a crisis, nothing is. We experience crisis fatigue. We burn out. Or we're so overwhelmed that we lose the ability to meaningfully engage. Problems become more salient, but too big to solve. So we likewise shut down and disengage. One of the biggest threats we're facing on the social determinants is inactivity or indifference. It's that there will always be another crisis, another priority that needs our focus, our energy and attention. And the way to counter this is not to dial up the crisis, it's not to rail against it, it's to channel efficacy, our ability to produce a desired or intended result. Efficacy is not hope, and it's not optimism. These two things are necessary, but ultimately they're both passive. Efficacy is our collective ability to act and to get things done. We need to talk more about how things can change, that people want change, and that in some spaces we're making change already. And this does two things. It helps us to tip social norms in favor of action, and it helps counter the fatalism that can cause people to switch off and disengage in a crisis. So we need to get explicit, not only about how our world works, but also how we can make it work differently. It's not enough to point out problems, to tell people to look up. We need to give people more. We need to pair problems with our ability to fix them, to talk about the urgency and severity of what is happening now, without leaving people at crisis point, without losing sight of our ability to put things right. So for every dose of urgency in our communications, we need to include at least 2 doses of efficacy, of confidence in our ability to make change happen. So that was a snapshot, some of the ways in which we can talk about the building blocks of health in ways that build understanding and drive support for change. And the rest are detailed in our toolkit. This new story is for everyone advocating for change, to an expert audience like commissioners, politicians, policymakers, and when communicating with the public. Because all too often, when we look at how people are talking about an issue, it looks a little bit like what's on screen. Different providers, different organizations, different practitioners, different communicators, sharing different things in different ways. And if you're listening from the outside, if you are not already expert, if this isn't already your world, it is really hard to hear a signal through all of this noise, to draw any kind of consistent understanding about our world. And we can't risk this on the social determinants of health. Lives are being cut short. The toolkit is designed to help us collaborate, to work together to tell this new story. Not everyone saying the exact same thing in the exact same way, but drawing on the same underlying frames to shift understanding in the same direction, to make sure that the understanding that we're trying to build really do take hold. Thank you.
Thank you, Tamsin, for that really engaging presentation. Although I've heard it in several forms before, it's fascinating. It's fascinating every time. Thank you for that. And it's really, I think it's really refreshing to have such a practical focus to a presentation and with some key takeaways. I'm going to bring in a couple of the other panel members now to share some insights on how what Tamsin has been talking about has been working in practice. So first of all, I'm going to turn to Tim. It'd be great to hear your experience.
Hi Gwen, yes, thanks. My name's Tim Andrew. I work in Public Health Scotland. We're Scotland's national public health agency. We found this research and insight incredibly useful. We use it in a few different ways, but always with the same purpose, which is to quickly convey important information to very busy people in a manner in which they can quickly take it on board. There's a huge range there. We provide evidence and advice up to the Scottish Parliament regularly, and we've found it valuable there as a way of bringing politicians quickly to understand the importance of the issue, what's driving an issue, and then also what action can be taken on it. And similarly, we've found it helpful with other policymakers and opinion makers. We've used it in briefings. We've used it in how we framed our strategic plans. And we are at the moment working on a set of, we call them strategic narratives, but basically little short stories about each of the policy areas we're seeking to shape and change for Scotland, so that we have at our heart a really tight way of talking about it. We have found it both a challenge and incredibly helpful. I don't know if you've ever heard that, I think it's a Mark Twain quote. I was going to write you a short letter, but I couldn't be bothered, and so here's a long one. And I think there's a quality of that that's true. It is really hard to communicate succinctly and well. And I think in the past, we've not done that as well as we could, but what this has helped us to do is just inspired us to keep going and to try and make our communications as good as we can. We have found it has been really successful at providing people with that we're trying to work with short things that they can quickly understand, and also, I think this is a real measure of success, repeat to other people. So it's not just, we're not as dependent on people having an expert knowledge of public health to convey what we're looking to do. And so, yes, so that's really the bulk of how we have been using it and plan to continue to use it. I spend a chunk of my time going around our organization, helping people craft their narratives. And, I can speak for many of our colleagues to say, it has been challenging, but extremely valuable to try and express ourselves well, and not just be great on the facts, but be great on how we convey the facts.
Great, thank you for that. Really, really helpful. And we'll hear a bit more about your experience in the question and answers. Liz, if I can turn to you next, I'd be really interested to hear about how you've been using the toolkit and what's proved most useful and valuable, and perhaps what some of the challenges have been.
Thanks very much, Gwen. So I'm here with my colleague Claire Laron, who works at Hertfordshire County Council. And we've been working together over the past 4 months to try and apply some of this to the local context, which is really important because there's so much that can be done locally, and public health departments have tried for a long time now to try and engage with policy partners, practitioners that don't work in public health with this narrative around the wider determinants of health and health inequalities. So we're trying to tell that powerful story that you have already mentioned in a local context, which, like with Tim, takes quite a lot of energy. So as a knowledge mobilisation person in a university, I've been facilitating this exercise with Hertfordshire County Council, and Claire can tell you more about working with the team. It's been a several stage process of first sort of engaging with the team, with the public health team, getting some time carved out in their busy days to engage with this new approach. And also through the development of my own research, sort of looking at other local authorities' experiences of framing the wider determinants and trying to engage with others on health and all policies or action to reduce health inequalities. So the process was engaging with the public health team and then having face-to-face several-hour session on thinking about framing and some of the local issues that are challenging, looking at local data, local strategies, local presentations, and to whom those presentations have been made, so who the audiences are, who are the people that we're trying to encourage this reframing with, and to what end. So there's been a lot of thinking and activity, and some of Claire's team have been putting examples to me of how you then make that frame alive to the local politician, to the local decision maker, so that action is seen as possible to overcome that fatalism or the fatigue, or to get over the kind of crisis language. So we've chosen some examples, one particular on food insecurity, and applied the framing and come up with a kind of a scripting or a narrative which can then be applied in different settings with different people, applied to presentations and applied to strategic documents. And it's probably up to Claire to comment on the sort of success or otherwise of that activity so far. But I think just on a point about using these framings, it'd be great to see some evaluation of how these things work in process and then in outcome in the short, medium and long term.
Great, thank you for that. Yeah, please do go ahead. Claire.
Gwen. And thanks very much, Liz. Yes, so I'm a consultant in public health in Hertfordshire County Council. My portfolio is a health inequalities portfolio, so very broad. And it takes in whole systems obesity, healthy places, and mental health and suicide prevention. So a whole broad range. And the messaging around health inequalities in particular is quite difficult, as I'm sure everyone on the call will recognise. So health is one thing, and yes, people talk about the NHS, but health inequalities is something that is quite complicated. And I think in Tamsin's videos, we saw how people immediately latch onto the top of the mind, I think she called it, top of the thoughts. And I think what can happen is someone does that, and you, as a professional public health person, get drawn into that argument and go down that narrow cul-de-sac. So what was really helpful with the framing work that Liz has helped the team with is to take a step back and to think about how you want to present what it is you want to talk about, and present it, go through the building blocks, and that reaching those solutions approach, which is really helpful. And it's helped the team think about their own work and how they talk about it and understand it, but also a good way to present it. So yes, Liz worked with us on one on food insecurity, which has its own particular language problems. A lot of talk about food poverty. Those are words that aren't particularly liked at local authority level. So food insecurity is helpful and also more accurate. So that was a useful thing to do. We looked at environment and healthy places. And we looked at mental health and our Gypsy, Roma and Traveller community. So all different ways of presenting that information. In terms of what the team have learned from it, they said that they felt it was useful in just developing their thinking and getting underneath the subject a bit more to present it. And they felt it would focus their messaging more on their audiences, so they could think about who they were speaking to and direct through the framing. So we haven't gone out wider yet within the council, but that's our next step, is to explain the process and then present some of our examples so that local councillors will recognise things in their area, whether it is food insecurity or whether it is to do with healthy streets. So it's that framing locally that people then recognise.
Great, thank you very much for that. Thank you very much for that, Claire. That's a really helpful additional insight. And we're going to move on to the question and answers. People have been typing quite a few questions in the box, which is fantastic. Feel free to add more if they come up, and also upvote the questions. One of the most popular questions that people had asked kind of reflected on the difficulty of getting elected members on board. And one of the comments was from a portfolio holder from Health and Local Government, who said that they found that it was a problem because health was often seen as secondary to more important issues like planning, etc., but that COVID was an exception, and that elected member colleagues find all the associated baggage wrapped around health difficult to understand, and that public health is sometimes seen as an add-on. So I wondered kind of whether you've got kind of an example, or how this has been helping have a different conversation perhaps with the local, with elected members. Tim, perhaps if I could come to you first, and then Claire, it would be really helpful to get your perspective as well.
Yeah, so I think it's worth starting by saying that the relationship between public health in Scotland and the rest of the UK in relation to local government is slightly different. So we are jointly sponsored by Scottish Government and COSLA, who are the national umbrella organisation for local authorities. And so we probably have a slightly easier starting point than some other situations. We have found the framing around that unfair difference is a really good starting point. And then the bit that we have found most valuable, and I'd encourage you to go and have a look at the toolkit for a really good explanation of this, is the role of explanation. So once we start off with that thing about, so in Scotland there's a 10-year difference between the life expectancy of people in our poorest neighbourhoods and our wealthiest neighbourhoods, and then when we go into the explanation about what drives that, we immediately find that chimes well with our colleagues in local authorities and local authority councillors, because actually most of it is not about the NHS. And so they can really quickly see how their responsibilities have an important role to play.
Great, thank you. And Claire, from your perspective, are there any particular kind of learnings and reflections about the different conversations that you've been able to have?
So I think that I'd recognise the barriers that came up in the question that happen in local authority. I think councillors have so much to think about that it can be difficult to take on one more complicated issue when they're not sure where the solutions are. So we haven't yet tested this approach on our councillors. We certainly intend to do that. I think that a little bit, as Tim said, it's making it clear why the wider determinants are important right at the beginning. So we may not use the language life expectancy, but whether people are living longer or less time, or the big gaps, is really important. That sets the scene, and that's certainly what we intend to do, and then work through why those issues are happening. So the building blocks, if you like, that are in the toolkit, which is really helpful, and that takes you to a solution. So a bit as Tamsin said at the beginning, it depends where you start with the problem in terms of how you get to the solution. So I think that's going to be really helpful. So we can report back, if you like, when we've done that as part of the evaluation.
Yes, definitely. And I think from our perspective at the Health Foundation, we're really interested to hear on everyone's experience of using the toolkit, whether you've been involved in the journey to date or part of the evaluation, or whether it's just or whether you you go ahead and use it after what you've heard today. It would be great to be collecting information about what's really working and what's resonating, and also some of the barriers. So I'm going to move on. The first question was about local government. I'm going to zoom up to central government. Another one of the popular questions that I think kind of was asked in several different ways was a reflection on what's happening at the national level. And Tamsin, it would be really interesting to hear your views here. We saw in the papers yesterday, in the newspapers, that the government was considering rowing back on some anti-obesity policies. And so the question was about, do you think that these sorts of communications are even more important at a national level? And I suppose what are the key points to take away?
I think there are two routes into affecting change, and I think that creating really well-framed conversations at both local and national are vitally important, more so now than ever. What I think is particularly useful in the recommendations is the focus on place, that some people in some places are dying earlier than they should be. And that can allow you to have useful conversations, both about place-based responsibility, local responsibility, and at that national level. And I think being able to be explaining how the context in different places is impacting on health and laddering up to what are the systems changes that government has responsibility for, that local government has responsibility for, is going to be really key to having those conversations in effective ways.
Great, thank you for that, Tamsin. Liz, I was going to come to you next, just with another one of the questions, thinking about the fact that people start from different knowledge levels, and that you might be having a very different conversation with a member of the public, perhaps an unengaged elected member, an engaged elected member, perhaps somebody who's really very interested in public health and wider determinants of health and some of the issues. I wondered whether there were any differences in the way in which you might approach those conversations, and kind of how that framing process runs throughout, regardless of the expertise.
Yeah, sure. I mean, this is part of the exercise with Hertfordshire, where we started with the kind of lowest hanging fruit, if you like, you know, the people that were already engaged in public health practice, and then moved through. The plan is kind of move through to different levels of interest and knowledge, you know, particularly to counsellors, because I think the whole thing does take quite a lot of thought and tailoring. I think in your toolkit you suggest different kind of like levels of emotional engagement needed depending on the audience, and I think some of the messages with a more engaged audience could be made, so a public health audience or with a policy audience, people working in practice, might be more focused on some of the sort of more detail around maybe statistics or examples that you've built into strategy or policy documents already, so you can go into perhaps more detail with the kind of examples around how life expectancy is impacted by the wider determinants, perhaps with more a local or everyday audience. I think it's probably focusing on the why it matters first and foremost, you know, that people in some places are dying sooner than they should do, and sort of repeating those sorts of messages. I think with the food insecurity example, we thought about using the term hunger, as has been recommended by frameworks in other framing work, because of its kind of emotional connection to everyone understanding what hunger feels like. And I think in those sort of everyday conversations, it's probably using those hooks that have more emotional resonance that could be helpful. So yeah, it does take quite a bit of tailoring. You do have to think about your audiences, but also I think it's really important to try and build relationships so that you do know who you're talking to most. And I think that's what we've been trying to do at Hertfordshire, is building those relationships first.
Yeah, thanks, Liz. And I think it is, I think when you start thinking about precisely what you're saying and how you're saying it, you do start to pay a lot more attention to the words that you choose, and that point about finding the words that resonate and have the impact that you absolutely want. I think you start to reflect more carefully about how to choose those. We've had a couple of questions about a different audience and perhaps a different segment that many of us will interact with, the media. And I think kind of some of the questions were reflecting that often the media like to be able to provide an individual angle on a story. So what can the reader do about this? Which again might it might reinforce the sense that, for example, around issues about obesity, that it's the individual's responsibility to take action, but also the media also quite likes a disaster and to present the worst of things, and not necessarily reflect on the hope or the fact that there is something that can be done. And I was wondering about kind of reflections of how this work might influence the media and some of the conversations that people on this call might be wanting to try to start with the media to try and have a slightly different discussion. So Tamsin, really interested to hear your thoughts on that, and then perhaps Tim as well from your perspective.
I think that's a good question. I think we often think we have less control over what is placed in the media than we do. And I think there is something in being really intentional and deliberate and strategic in having those conversations. One of the ways in which we do frame testing is also technical term, we test for stickiness, how likely people are to take up and repeat concepts and ideas. So they can be a really helpful tool in starting to have those conversations and in making sure that the ideas you're activating, the frames that you're deploying will be repeated and shared. I think there's a broader implication to the question, which is, how do we support people to tell their stories about health inequality and health disparities? And it's something we do a lot of work with across the different social issue areas that we work in, how we can support folk to share their stories with the media, with politicians, with practitioners in ways that do justice to what has happened and how they want to talk about it, but can also, when they so choose, deploy the frames. And I think that you need to take both angles, to both be strategic and intentional with how you have conversations with the media, and you also need to be supporting folk who have a story to tell it in a way that is safe and effective.
Yeah, so we're quite early on in our journey of using these tools, so I can't speak from experience of engaging with the media on it. However, I go into it feeling quite optimistic. Some of the things, I spoke before about the section in the recommendations on explanations, and one of the things we have found challenging, and in the best possible sense in there, is the way that we explain issues. And the thing I like from the toolkit is that it's about talking through the relationships between different factors, and it's often done from the perspective of an individual, and we can all relate to it. In the past, we have tended to explain things from a sort of societal level, and it's tended to be a little more abstract and technical, which is, as public health practitioners, how we look at the world and how we are trained, and that is a good thing, but it's not always the most effective way of communicating it. And I think what that shift in how we explain things is going to be helpful when we're really relating to the media, because it takes it down into terms like Liz was saying around hunger that we can all relate to. And while not all of many of the issues we're talking about are not amenable to individual action and will require something more systemic to change, I think it helps just shape that public understanding that that health is beyond just, as Tamsin was saying, it's focused on place and the situations we find ourselves in, rather than just whether we are, lazy or stupid, as some places would have you believe. So I feel quite optimistic about it, but also challenged because it's a change in our default and how we're used to talking and looking at the world.
Yeah, thank you for that, Tamsin and Tim. I think it's a helpful reminder of the power that we do have to present the work that we're taking forward in a particular way. And I think I was also interested to hear you mention again, Tim, the kind of the power of place and about making it relevant, because I think that's a theme that's spread through several of the answers. I'm going to turn to Louise next. One of the questions that's been upvoted has been about the language that we use. So whether we should be talking about health influences rather than determinants, given that influences can be more well understood.
Thanks, Gwen. And I think I completely agree. And both health determinants, health influences can be seen as a bit jargony potentially, which we try and avoid. We use both, I think, depending on the context we're writing in. We talk about wider determinants. Other people, I think, use socioeconomic determinants as well. But we also talk about the things that influence our health. And for me, a really interesting and key part of Framework's research was the testing of the metaphors and the finding that talking about the building blocks of health was a really productive way to talk about these determinants or influences in helping people to understand the way that they work together to influence or determine our health. So yeah, I think mixing it up a bit sometimes it can help it feel like you're not repeating a term and using sort of jargon terms. But I really like and have been testing out the building blocks metaphor and have been really interested to see it appearing in other people's communications actually recently as well. It does seem to really resonate.
Thanks, Louise. And Tamsin, I think there was a point that you were keen to come back on following Tim's comment about individuals in context.
Yeah, I think that was such an important point of that Tim made, because what we're not suggesting is to go one way or the other, to only speak about systems and to avoid individuals entirely or vice versa. It's getting that balance right. It's placing an individual in context, often in place-based context, that will do the work that we need in shifting people's thinking.
Great, thank you for that, Tamsin. I wondered whether actually I might be able to stick with you both with the next question. I think we've had a variety of comments from people who really enjoyed seeing the videos and kind of hearing and viewing the thought processes that people went through. A question about how the public mindsets about what causes health differences differs across countries in Europe, or even whether it differs in Wales and Scotland, and whether there's been any work looking at this and the factors that contribute towards the wider determinants narrative. And then I think perhaps linked to that as well, we've had another set of questions about how this resonates with minority communities who we know are most at risk of experiencing poor health. So perhaps if it's possible to pick up those points. Tamsin, shall I come to you first, and Tim, you can then pick up the Scotland angle. Thanks.
Cool. I think really important questions to surface. So when we do testing, when we do recommendations, we draw on representative sample sizes across the demographics of the 4 nations that we're operating in. So it will have been tested with a representative sample based on the demographics of the 4 nations as a whole. The videos in particular are illustrative. They're essentially who was willing to stop to have a conversation with us on the streets. But they're backed up with those broader, more representative data sets. And the reason we seek to engage representative sample sizes, the reason we seek to engage as many people as we can is because we know how mindsets are formed. I think I mentioned before, mindsets are implicit and they're shared across a culture, because we're all susceptible to the influences of the culture around us, what we read, what we hear, the news sources that we take in, or the books that we read. What we do find is there will be variations in dominance of different ways of understanding the world, but those same underlying mindsets will be present regardless of who you are or where you come from. That said, I am always in favour of doing additional research where and when we can.
Yeah, and in terms of Scotland, I don't know of anything that would suggest that mindsets on this are any different in Scotland from any other part of the UK. What I think the challenge can be in Scotland is that, you know, it's well established that health in Scotland lags behind the rest of the UK and the rest of Western Europe, and it's well established that we have poor health inequalities, and that those are focused in, you know, quite geographically specific areas. And the issue that creates for us around communication sometimes is around just a bit of fatigue and a bit of fatalism. So, you know, particularly when we're, you know, framing the issue, there's a bit of it where it's like, you know, people sometimes like to talk about well-being if they're talking about health a lot, because it feels more positive, and it is a hard message. You know, if we keep talking about how health in Scotland is lagging behind and how health inequalities are large, and people find that tiring. I think also, you know, Tams, when you're presenting, you were talking about that, the importance of showing that we can make change. And the other thing that we need to, I think, work on hard in Scotland is about showing that change is possible. There is nothing that means that Scots are inherently going to die earlier than other people. Like it is something that we can change. We have risen to public health challenges in the past. If you look at some of the stuff we managed to achieve in the pandemic, it shows that society can work together to save lives. It's not inevitable, and so we need to sort of push back, I think, on some of that fatalism that can sometimes, or even just the complacency that occurs when we become used to a stark and difficult fact like health in Scotland. So no difference, I think, in terms of the mindsets that approach health, but maybe a different context in which we're trying to apply the tools.
Gwen, may I just come in to talk a little bit about what, so I think there is a link here between sort of cultural issues and the media presentation. So what my team found when they were putting together their presentations around their work was the really high value of having a video, a bit like Tamsin did. It brings people down to earth. So we had one of the teams, we did one on suicide prevention and looked at, in particular, the Gypsy Roma traveller community, and the team ran a video about the high rate of suicide among the Gypsy Roma traveller community. It's 7 times higher in that male community compared to the wider population, 6 times for women, and had a video just with some of the community talking about their experiences of suicide within their families and very high rates of it. That was really powerful in terms of getting across that message, how these wider determinants can affect individual people, but also to the link to cultural issues that people may not be aware of. And the other one we looked at was to do with prostate cancer, which is predominantly higher in Black men, and ran a video there with Steve McQueen, the director, whose father died of prostate cancer. And that was an incredibly powerful, but very short 2 minutes video of talking to various different Black men about the experience, which made it pertinent for that group of people we might be trying to reach. And also it brought in those sort of wider cultural issues as well as the media bit. So I just thought that was quite a useful thing to think about including in any presentations people do, just having the video linked to personal stories.
Great, thanks for that, Claire. That's really helpful. I wonder, next question, there've been a few comments about kind of how to make the change and how to build confidence in doing this. And I know, Liz and Claire, this is something that you've been reflecting on locally, that this large challenge to change the culture of public health and collectively build confidence to do things differently. What are the key reflections that you give from that piece of work that would be helpful to share?
Sorry, was that to me?
Yes, Liz and Claire, yes, thank you.
Do you want to go first, Liz?
Okay, I can go first from the outsider looking in. So again, I suppose there were sort of three sort of headline challenges, I think, when doing this sort of work that might act as a barrier, but they're, you know, things that can be overcome in time, and that's the confidence issue. It's a consistency issue, and then worrying whether or not you're being consistent. I think that's a challenge for people working in this area. And then coverage, you know, so how far do I go, and is that far enough, and how do I know it's making a difference? And also there was a message in the chat about the messenger. So am I the right person to say this? Who is more important? Is there a power structure to this communication? You know, who should I be reaching? So confidence, consistency, coverage, those are all kind of issues. And for outside person looking in, so I sort of taken on the role of a facilitator. So I'm supporting as a knowledge mobilisation sort of specialist, really, working in that local area, and recognising that that's not feasible across the board, across all local authorities. But there is an issue there about what is within the public health infrastructure in terms of research and knowledge mobilisation that will facilitate these conversations at local levels. So the NIHR, for example, National Institute for Health Research, is an infrastructure that's really well established across the NHS, and I know that much is being done now to try and improve that infrastructure across public health research too. So it's not realistic to have that kind of facilitation to help build confidence, because a lot of confidence building is about being together, building relationships, having kind of credible, legitimate evidence in front of you saying this thing is a good thing and it will help and it will work. So you've got that in the Health Foundation and frameworks work, which is fantastic. But then sort of having those enablers, and there might be people like me that cross the boundary, or people like Claire, who's a consultant who can sort of support public health to in her team to have confidence in this. And then it's kind of repetition, so being able to take the basic three main points from the toolkit and apply them in different contexts, and that just takes a lot of repetition. Having those examples to hand, so tailoring examples too, I think that builds confidence. But then it's also having the reactions and knowing what the reaction is with your counsellors, with your co-workers, sort of feeling confident that you're not going to be ostracised, or that you're not going to be taken seriously. Those sort of things help build confidence. But Claire, I don't know what the team have been saying since you built your extra examples.
So I think, yes, a lot of it is around the confidence and consistency issue. I think that, so two things really. The pandemic produced a lot of experts around health inequalities. So a lot of people who knew about suddenly became interested in health inequalities, but perhaps had different views and perspectives. So I think that the framing work helps to focus people's minds and the information, so that there's a consistency around understanding what health inequalities are. And I think that public health needs to recognise that while they may be the experts, one of their skills is to encourage others to take on the knowledge and to understand the issues and to go out there and talk about things more widely. So it isn't just health inequalities having the information over here and being the experts and everyone else has to keep coming to them. It's about others understanding through that messaging what the health inequalities issues might be and being able to do it themselves. So there's a kind of a spread of knowledge and a sharing of knowledge. And I think the consistency is really important. So there may be that coming back for that repetitive message, just to hear it again to be sure that you know what it is. And the coverage is really important. The pandemic alerted people to all the health inequalities issues. So coverage is huge, but we're trying to make that message consistent, and I think this helps to do that. And yeah, we can report back how it goes.
Great, thank you both. And we're coming to the final set of questions. Louise, it would be really helpful to kind of hear about next steps. We've had some people reflect how everybody involved should be in any sort of public health messaging needs to watch the videos that have been included in the presentation. And then I'm going to briefly come to everybody else, perhaps given time for your one top tip for somebody who's new to this, and kind of what would you want them to have taken away from this presentation? So Louise, I'll come to you first.
Thanks, Gwen. Yeah, we've been absolutely delighted and blown away by how much interest there has been in this. And as you've heard from Tim and from Liz and Claire, who have had the experience of trying to implement some of this, there's some really valuable learning, and we are really keen to learn more about how this is actually implemented and used in practice and the impact that these ways of communicating can have. So yeah, absolutely. We are speaking with Frameworks Planning sort of follow-up work to understand more about implementation and to be able to share that with you, and obviously about the important impact that it might have.
Thanks, Louise. So I'm going to go around my screen. So Liz, what would you hope people take away, just briefly?
That you're already doing some of this, and this toolkit will help make the task probably easier rather than harder. So look at what you already do and then tweak it. That's what I think would take away.
Great, thank you. What a fantastic recommendation for the toolkit. Tamsin.
Oh, I want to. I'll keep it to one. I think it's the idea that we've touched on a lot already, that we don't change the frame, but we can absolutely and should tailor how we articulate the frame and through what medium and with what form of words, depending on the audience. And that flexibility is baked in, and there are lots of different examples in the toolkit.
Great, thank you. And Claire?
Sorry, can you hear me?
Yes, I can.
I was going to say change the frame, because take control of the frame, which I think perhaps is what Tamsin said. But the other thing is the building blocks. Think of those, and that helps take you through the problem and to solution. So maybe two things there.
Thank you. And then last but not least, Tim.
Yeah, so I think there's a bit of this where you succeed just by doing it and keeping doing it. There's a skill here, and practice makes perfect. Like folding your arms the other way, it feels a bit weird at first, but you soon get into the way of it.
Great, thank you. And so, well, thank you everybody for coming along and for a fantastic set of questions and answers. And we're going to close with a final poll about will you use the toolkit in the future. So just really interested to kind of hear whether you've been inspired by what you've heard today. So I think that poll will come up in a moment. Oh, fantastic. And while you're filling that in, if you are interested in keeping in touch with us, we've got a particular piece of work that we're undertaking with Solace, looking at prevention in health and local government. So if you're local government officers, we've got that particular piece of work. Do reach out. If you are undertaking work with the framework, we really want to hear how it's going on and how you're finding it. Caroline, are we going to see the results of the final poll? Fantastic. Oh well, my goodness, 99% of people. What that really warms my heart. So thank you, and thank you very much for listening to this conversation. As I say, it's going to be on the website tomorrow, so if you enjoyed what you've heard and you want to recommend it to colleagues, they'll be able to listen to it. And I think from the comments that we heard made during Tamsin's presentation, I think a lot of you are keen to share that, so you'll be able to share it in that medium. And please sign up to receive updates on our webinars. There's a link on the screen. So thank you very much for your participation today, and goodbye.